All right, let's get started. All right. Hit the recording button. Stop recording. Okay, thank you. Okay, good morning, everyone. It's a pleasure to have everybody join us at today's webinars hosted by Conception, and joining us is Dr. Sara Mucowski from Dallas IVF, is top fertility expert in the area. And today, Dr. Sara Mucowski is going to tell us the story of her own and some of the concepts about egg freezing and the donation. Because lately we understand the holiday season is approaching. For some younger female, one of the good gifts that you can give it to yourself is to reserve the opportunity for the future and so you can plan your more advancement and progress on your academic achievement or career progression. So without further ado, I'm going to pass the host to Dr. Sara Mucowski, and she's going to tell you more about egg freezing and donation.
Absolutely. Well, thanks so much for having me, Vi. I'm really excited to be a part of this today and to share my story on egg freezing and kind of what that process looks like, both as those who are freezing eggs for themselves and those who are considering donating eggs. So I think one of the biggest misconceptions that gets kind of portrayed, even from when we're real little, right, is the idea that fertility is easy. This is something that we all should be capable of doing, and it's expected almost, right? I think we've all heard some version of, all it takes is when two people really love each other. And then as we get older and learn a little bit more about the science behind it and the actual biologic component of reproduction, it makes it sound like all we need are the right parts, right? We need access to sperm, we need access to egg. They need to meet together, be put in a uterus, and boom, instant baby, right? That's all it takes. But unfortunately, we learn as we get older that there's a bit more to the story, right? There are a lot of things that can have an impact on fertility, especially not only in the moment, but also sort of lifelong, right? So the idea of the biological clock is very real. Women are born with all the eggs they're ever going to have, and they don't make any new eggs with time. So that's definitely something that's a huge component, especially in modern scenarios where we tend to delay childbearing. We have really great access to birth control in order to do that. And it takes longer to get to where we want to be in a career perspective, right? The idea of being a reproductive endocrinologist like myself today certainly takes longer to get to that point than it may have, years ago. And so in planning for that, it's important to kind of recognize the biological clock aspect and future fertility. There's also anatomic issues, things that can disrupt the tubal patency or how open the tubes are so that sperm and egg can even get together or that embryo can get from the tube into the uterus. There's the idea of endocrine issues like polycystic ovaries or other anatomic things like endometriosis and fibroids. Certainly there's things that can impact the sperm as well as to the female side of things. And some of these things are the same regardless of gender. Some medications you're taking, toxins you're exposed to, things like plastics and cigarettes certainly have a negative impact on fertility. And we're also seeing more data kind of with our very Western lifestyle that BMI or weight also has a negative impact on fertility as well. So one of the things I tell all of my patients as far as the egg side of things goes is I use an analogy like a can of Coke, right? As I said, women are born with all the eggs they're ever going to have. And that's about 1 million or so eggs at the time of birth. And this number is only going to decline as we get older, right? So just like that Coke analogy, if I were to give you a can of Coke, all the bubbles it's ever going to have are in that can when you get it. And once that can is open, there's nothing you can do to make bubbles or save bubbles, right? So the idea is that a real fizzy Coke is like puberty and a flat Coke is menopause. All right, so the idea there then is kind of, again, the same thing we're seeing with this graph is that the decline in the number of eggs as we get older. One of the things I want to highlight here that I think is something we really just don't hear enough about is the idea that most women think that you're fertile until you reach menopause. But the reality is, while you still may be menstruating appropriately or regularly, and that you still have eggs available, the quality of those eggs is also declining as we get older. And so we actually see that the end of natural fertility, or that reproductive window, closes at about 10 years before menopause. So menopause in the US on average is happening at around age 51. So that means the average woman, their reproductive window is closing at around 41. So definitely something to consider, right, when you're making your long-term family goals and plans, and then kind of factoring in what maybe other professional goals or travel goals and those kinds of things that are in play, kind of where that all comes in together and sort of how to plan for all of it. Because I do think that women can have it all. It just takes a little bit of planning. So again, same idea, just a different graph representing the idea that the number of eggs, which is the follicles. So back to the Coke analogy, follicles are sort of the little bubbles, right? So when we do a baseline ultrasound, we can actually see some of those follicles, which we call antral follicles, or the ones that are resting at that point in time. And that's like looking at the layer of bubbles before they pop. So that ultrasound doesn't tell us how many are there overall, or who's going to be able to respond to treatment, or anything about egg quality. Doing that baseline ultrasound is just kind of getting a snapshot of fizziness. And so the same is kind of looking at those follicles. So we see in this graph, the number of follicles declines as we get older. And again, back to the idea that the quality of those remaining eggs is diminishing as well. You see that the abnormal oocytes or eggs is rising as we age. And that's why we see kind of going hand in hand. Not only is it harder to get pregnant as we get older, and that's due in part to the decline in the number of eggs or number of follicles, but that when women do get pregnant in what we call advanced maternal age, or as we get older, there's a higher rate of miscarriage. And that's because of those abnormal eggs that are in the pool, that they aren't genetically capable of resulting in a healthy pregnancy. And it's those genetic errors that happen at the time of fertilization, that there's either too much or too little DNA, which is overall, that umbrella is called aneuploidy. The aneuploidy most people are familiar with is Down syndrome, right? An extra chromosome 21. But the reason we're not as familiar with other aneuploidies is that most of them don't make it that far. So typically those types of mistakes are the most common cause of miscarriage at any age. And we think it's due to the poor egg quality, that those poor quality eggs make more mistakes, more aneuploidy, more miscarriages. So ideally, the younger the eggs, the better the number we would be able to harvest, and the better quality we're preserving for the future. Believe it or not, I mean, overall, the field of reproductive medicine as we know it is pretty young. First IVF baby was born in 1979. The first attempt at helping sperm fertilize with ICSI was in the 90s. So this is all still a very evolving field. And it really wasn't until pretty recently that both the American Society of Reproductive Medicine and ACOG had come out with statements regarding egg freezing. So this graph is from the statement from the American Society of Reproductive Medicine. They made their stance public in October of 2012 at the annual meeting. And then it was published in January 2013. And the big take-home number here is what I have highlighted in green. So the CPR is clinical pregnancy rate. So we have clinical pregnancy rate per transfer of vitrified or vitrification. That's our super rapid, ultra fast frozen eggs. So they minimize the risk of developing ice crystals inside compared to using fresh eggs. And you can see that statistically, there's no difference between the two. So this is kind of the big push that removed the experimental label on egg freezing. And again, that's largely because of the changes in technology that allow these eggs to be frozen so fast that we have little damage to the egg compared to kind of the slow freeze process that was around forever, where we saw ice crystal formation inside the egg that could cause damage in the freeze process as well as damage in the thaw process. So again, technology is fantastic and has advanced to a point to where egg freezing is now no longer considered experimental. One of the big concerns out there, and again, this is because of how rapidly evolving the field of reproductive medicine is how long it takes to do an egg freeze or even an IVF cycle. So this is a sample treatment cycle, and it's very similar to the protocol that I used when I froze my eggs, looking at kind of how long it takes to do the process. Now, granted, this is not including that initial meeting with one of the reproductive endocrinologists to talk about whether or not you're a good candidate for this and what that looks like and kind of getting the medicines and everything to get ready to get started. But once we kind of make that call, it's about a 2-week process. So you do take shots. at home. They're real little needles like an insulin syringe. So if you numb your belly up with an ice cube first, you really shouldn't feel much of anything. But it does sometimes have some bruising, redness, irritation at that injection site. You take those shots called gonadotropins for, on average, about 10 days. You do take 2 of them usually. So one of them has an FSH component and the other one has an additional LH component. So those are the gonadotropins that your brain normally makes to stimulate the ovaries to grow. How this works for egg freezing is because we're giving shots, we're stepping in as your brain. So instead of just one follicle or one egg selecting out as the winner and then signaling back to the brain and tell it to, hey, back off, I got this, we step in and tell all of the follicles that would have otherwise been competing that month to keep growing. So we're not pulling follicles forward that would put you into menopause early or anything like that. We're just stimulating eggs that would have otherwise died off to keep growing, to give them a chance. So like I said, it's an average of about 10 days that you're taking these shots. You may be seen anywhere from 3 to 5 times during that, so roughly every other day, just for quick visits, blood work and ultrasound. We use those 2 pieces of information to determine what, if any, changes we need to make to the medicines and when we can anticipate being able to harvest the eggs. Somewhere usually around day 6 or 7 or so of the stimulation process, we add in an additional medication called ganirelix or cetrotide. So this is a GnRH antagonist. And so what that does is it tells the brain not to stimulate ovulation. So now we have multiple follicles growing. We don't want them to ovulate early, right? We want to be able to access them so that we can freeze these eggs or utilize them for an IVF cycle. So at the end of that 10 or so days of these shots, assuming the follicles look appropriately, growing appropriately, and the amount of estrogen they're making is appropriate, you take one last shot, and that's what we call the trigger shot. And so what that does is that's going to help mature the eggs. It's going to release the eggs from the wall of the follicle or the cyst that they're growing in. And that allows us to be able to access them with a vaginal ultrasound as a really minor day surgery procedure so that we can then freeze them for the future. Most people go back to work the next day without any issues. So realistically, it's about 12 days. And then the eggs are frozen indefinitely for when you're ready for them. And you can go back about your regular, you can go back to work, you can start going back to activities, that kind of stuff. So it really is a very small window that it takes to really, have these eggs frozen for your future. So here's just a schematic of sort of how the egg retrieval process happens. Like I said, you are asleep. You're not going to remember anything. You're not going to feel anything. But it isn't full anesthesia in the sense that you're breathing for yourself the whole time. It's a vaginal ultrasound, so just like what we see here on this image. And there's a guide on the ultrasound screen, so there's a kind of a dotted line. So I can see where the needle that's on the other end connected to tubing and suction, that needle just goes through the vaginal wall and right into the ovary. So as the ovaries are enlarged with multiple follicles, they're not kind of hanging out in that traditional picture that you see kind of in a textbook, right, where the tubes are hanging out here and the ovaries are so far away. They actually get heavier and they're kind of laying right on the top of the vagina. So that way we don't have to worry about necessarily dealing with other organs that are in the way. So damage to bowel, bladder, that sort of thing is very, very rare. So it's the needle that goes into the follicle. And then because that needle's connected to tubing and suction, we drain the follicle. And that way, under the microscope, we can find the eggs. Risks of the procedure are very minor. The most common things we see are bleeding and infection, and that happens less than 1% of the time. Like I said, the day of surgery, you take it easy, right? You got anesthesia. You don't want to be making big decisions or driving, that sort of thing. But most women go back to work the next day without any issues. And then once the eggs are frozen, they're suspended in liquid nitrogen, and they seem to be good indefinitely. So they don't know that they've been frozen a day, a month, 10 years, right? So again, the idea is the younger we freeze eggs, the better quality eggs we're receiving and potentially a higher quantity of eggs as well. So this may be something to consider not even just for baby number 1, but baby number 2 or 3 or 4, right? So this isn't something that's necessarily just a short-term thing, but we're trying to want to plan ahead for your entire family building goals. So regarding the egg freeze process, it's pretty much the same whether you're going to freeze eggs for yourself or if you're planning on being an egg donor. right? Everything is the same once the eggs are harvested. If you're an egg donor at that point, the eggs are no longer considered yours and either go to an agency or the intended parent and are fertilized to be created into embryos for pregnancies in the future with the intended parents. In some of those cases, we may be looking at using a gestational carrier or what's considered a surrogate. Lots of indications for why women need gestational carriers or surrogates. Certainly women who have medical indications that make pregnancy unsafe, right? So they may have severe diabetes or high blood pressure or other issues that just wouldn't necessarily be a good candidate for being pregnant. Or someone who maybe had a really traumatic delivery and had previous pregnancy complications that could be life-threatening if they were to encounter those again. So we want to maybe continue growing their family by using a gestational carrier. Sometimes we consider using a gestational carrier in women who've undergone IVF, but for whatever reason, despite transferring good quality embryos into the uterus, they're unsuccessful in getting pregnant. So maybe there's a uterine factor there that needs to be addressed, and we want to use a uterus that we know has been proven to be capable of not only getting pregnant, but delivering a healthy baby. In some cases, there's severe fibroids, which are benign kind of tumors of the uterine muscle, end up becoming an issue that can make the uterus not a very hospitable environment. Or if someone had a hysterectomy for some reason and still wants to grow their family, we can use a gestational carrier to do that. So by definition, technically, there is a difference between gestational carrier and a true surrogate. So most of the time, the terms are used interchangeably, but from a legal perspective, a true surrogate is someone who it's not only their uterus, but their eggs as well. So in most cases, we want to try to avoid that for issues that you can imagine regarding kind of ethical, emotional, legal concerns. We want to do the best we can to protect the rights of the intended parents. So we want to make sure that those who want to be parents have the rights in place for that, and that those who don't want to be parents are also protected. So like I said, technically gestational carrier is a little bit different than a surrogate, even though those terms are used interchangeably. You can use both a known gestational carrier or someone from an agency here, just like Patriot Conceptions, that gets matched to you. And there's pros and cons to both of those, right? So one of the things, if you're using a known gestational carrier that could be of concern, certainly are the emotional issues, any legal concerns, right? Like I said, we want to make sure that all of that is very much established from the baseline so that we're not having, ending up in kind of a sticky situation where now the gestational carrier, say, wants parental rights, or there are other issues that maybe we weren't anticipating beforehand that now we're encountering, and maybe the gestational carrier and the intended parents aren't necessarily on the same page. As opposed to, say, using an agency where a lot of those things have already been taken care of, and it's very clear cut and well established from the get-go. So I think this is going to be where kind of Bal picks up on their side of things on the slides. So I'll kind of go ahead and relinquish control back to you.
Okay. All right. Thanks, Dr. Mucowski. And at the end of the webinar, we're going to have a FAQ session. So we are live streaming to Facebook and YouTube. So at the end of the webinar, we're going to collect everybody's answers, and hopefully we try to get most, if not all, addressed. Yeah, surrogacy costs can be nowadays can be high, especially in the state of California. But like Dallas or the surrounding South or Texas area has that advantage, is the surrogacy costs can be significantly lower. And also because of COVID, the pandemic, we also launched new programs not on this presentation. So what we do is called independent journey options. So pretty much we only charge a flat search fee to find you ASRM compliant surrogate. Of course, we still screen them, get their background check, their medical records, make sure they're ASRM compliant. Then you will manage your journey independently by yourself. So with a typical agency price sheet, this is fairly typical, and actually in California we're quite competitive in terms of the pricing. So the breakdown of why it would cost over 6 digits for your whole surrogacy journey is that for the surrogate screening and the management, that includes the agency fees, will cost a big chunk of money for us to do the background check, usually through a private investigator. Soft pull on the driver record, and also their credit history to see if there's any outstanding debt. So we don't want the money to be the primary MO in this case. Um, and the legal fee, it differs from state to state. In California, normally it consists of drafting of gestational surrogacy contract for the intended parents. And also we also would recommend an independent attorney for the surrogacy side to do the review of the surrogacy contract. And after the contract is signed, the surrogate went through the IVF cycle, did the transfer, get pregnant. By the time they graduate, normally it's 10 weeks after they start their journey. They will in California, and I think that it's the same case in Texas. They will do what they call a pre-birth court order. So prior to the birth of the baby, you will already have legal paperwork to say to establish intended parents' parentage in this case. Surrogate benefit package that includes the base compensation to the surrogate. Normally, that's payout after they get pregnant, um, and also the monthly miscellaneous allowance to cover their mileage, parking, travel back and forth between their home and the clinic, the prenatal supplements, etc., etc. Some other common stuff like maternity clothing allowance, because once their body starts to change because of pregnancy, they will need to buy new clothes to that conforms their body. Surrogate insurance can be another big chunk. What we do want our try to have our customer do is to take advantage of the open enrollment period. The uh, in most states, in California, it's a little bit different because they extended it a bit. But in most states, it's from November 1st all the way through December 15th to cover surrogates maternity care. If you miss that window, it doesn't mean you couldn't get it, but the options are less widely available, and you might have to get a specialty insurance, or some parents choose to pay cash in that case. But of course, there's a greater risks when you decided to pay cash, which we would not recommend. But in general, that costs about 15K. Um, and like I say, if you miss the open enrollment window, that could be significantly higher. And I also want to say about the independent journey option with us. Like I said, we only charge a flat fee for in that case. So let's say if you want to find a surrogate in Texas area and complete your journey with the Dallas IVF, if you choose to do independent journey option, the total price can be lower from a six digit like 100,000 to somewhere around 70. So it's going to be significantly lower. But the drawbacks that you're gonna have to handle this all by yourself. So how the screening and matching process works with us is normally uh, all our surrogate are pre-screened, from the background medical records and all the social situation. All guys, sometimes we do send private investigator to do a home visit to make sure that she has a good living environment too, and we will present those qualified candidates to you for you to. We do have an online profile system for you to choose all these candidates, um, and then once you find the candidate that you're interested in meeting, we will set up the meeting either in person if you live close to each other, or you will do it online via Zoom call, for example. And with us, we do have an online system for you to do all that. So if you're on your screen, you can click on Learn More to go to our page to learn about that process. And then once you get matched with a surrogate, you will start. The surrogate normally will be screened by intended parents physician. Let's say the intended parents have their embryos with Dallas IVF, Dr. Mucowski. And then the surrogate will fly to Dallas to do the medical screening. And Dr. Mucowski already mentioned, what they're looking at in terms of what the medical qualification of a gestational care candidate. There are FDA required tests. In addition, the physician will check their uterus to see uterus lining is appropriate, have the appropriate thickness, and if there's any internal scarring from or cyst. In California, we know there's a lot of cyst removal before they become a good candidate. Then we kind of explain how the legal process works. Normally, there's a surrogate contract part, then there's a parentage establishment after the IVF graduation, and after the 10 weeks at the IVF center, then she will go back to a normal OBGYN office until she delivers the baby for the intended parents. And because of the legal paperwork already established the parentage on the birth certificate in majority of the states, you will already have your name on it instead of the gestational carrier and a partner's name. But it still is different from state to state. In certain states, they do it post birth, and unfortunately, out of the 50 states, there are 3 states that are really difficult to do so. Well, Michigan and New York is outright illegal, and Nebraska and Louisiana is quite challenging. But the good news is, New York passed the legislation, so starting from next February, the commercial surrogacy will again become legal in the state of New York. Okay, and we understand, financing could be a great challenge for anybody looking at to do a surrogacy journey. That's why we do partner with several different financial institutions to offer you financing options. You can borrow up to 100,000, and with the terms expand to all the way to 84 months. Of course, so right now, because of pandemic, the Fed dropped the long-term rate to at a pretty good number. So that's definitely something to take advantage of. Other stuff that you might consider and actually might be more favorable is that if you have a positive equity on your real estate property, a cash out refinance, because you get to enjoy the long-term low interest rate, and it got spread out into either 15 or 30 years, or if you have adjustable mortgage, still that's like 5 to 7 years. So a HELOC, home equity line of credits, those are all long-term low interest rate options for you. Again, I'd like to mention that independent journey option. That's something you definitely should consider if you like to take advantage of a low cost option. And I think that conclude my part of the presentation. Before we move to FAQ session, I just want to give everybody an opportunity to, if you're interested in doing egg freezing, or you like to have a consultation with Dr. Mucowski, I'm going to send out a link on the center of your screen, so you can book the appointment with her. Just bear with me for a few seconds. Yeah. Okay, so if you'd like to book a consultation with Dr. Sara Mucowski, go to the center of your screen, click on Learn More. That'll redirect you to Dallas IVF's webpage, and fill out your brief information. Then the representative from Dallas IVF will contact you in that regard. Okay, so the next we're gonna try to get as many questions answered as possible. Our mediator will go to Facebook and also the YouTube. We also have a live streaming program on WeChat, to bring some Chinese or Chinese American guests. So they might have questions. And also, this is the if you like to follow us on social media, this is Dr. Sara Mucowski's Instagram and our Instagram page. So feel free to do so. So let's see. Okay? Let's go through the question from this live webinar program. The first one is, Dr. Mucowski, do you recommend to freeze egg at age of 25 or age of 30? If I freeze too early, will it affect the quality? I'm afraid.
So again, in theory, the younger the eggs, the better, right? So that we get potentially more eggs and better quality eggs. Now, having said that, on the extreme side of things, we can see that really young eggs may have poor quality as well. These are usually women in their really, in their teens still. So I would say 25 is a great point to be freezing eggs. That's kind of in that peak window of fertility. That's in the natural kind of progression of things. So I think that would be a really good spot. Me personally, I froze mine at 30. In part because egg freezing was still experimental when I was in my 20s. So I may be dating myself a little bit there. But also for me, I wasn't really sure what my future was going to look like at that point in time. So as I was turning 30, I kind of had a better idea of what I expected my life to look like professionally. I was already in the process of my reproductive endocrinology and infertility fellowship, which is a 3-year fellowship after 4 years of OBGYN residency, after 4 years of medical school, after college. So I knew that once I finally kind of reached that peak of finishing training, it was going to be important for me to start growing my practice and seeing patients and kind of really enjoying that enriched side of things professionally before I'd be ready to do things personally as far as growing my family. So that was kind of the age where I sort of felt comfortable with that and sort of, again, predicting for the future, knowing that I was at a point where I could still potentially conceive naturally on my own, but then maybe use those frozen eggs for the second or third kid or whatever things looked like as I got to that point. I think the other component that was kind of with one of those questions was regarding kind of side effects or concerns about the procedure itself. So like I said, with the actual obtaining of the eggs, it's a very minor day surgery. It takes maybe 30 minutes. You're completely asleep. You're not going to remember anything. You're not going to feel anything. And there are no incisions, so there's no scars. With that, like I said, the most common issues are bleeding and infection. They happen in less than 1% of all IVF patients. So not just egg freezing, but also patients who are attempting to conceive at that moment in time as well. Much less likely would be damage to stuff nearby, right? Your bowels are below, your bladder is above. There are nerves and blood vessels that feed the uterus and ovaries. But again, we're seeing everything in real time with the ultrasound before using the needle. So very unlikely that anything like that would occur. There is a possibility of something called ovarian hyperstimulation syndrome, or OHSS, which is very rare in this day and age. We have ways to help prevent and treat OHSS that we didn't even have, say, 5 or 6 years ago. It does happen more often in really young women, so usually women in their 20s who have multiple follicles on either side. But again, because of the newer technologies and the medications and things that are around now and what we know about OHSS, it's pretty unlikely. But when we do see it, it's usually just more bloating and discomfort, because part of the issue with OHSS is that blood vessels get leaky. So you've got your normal organs in your belly, then your ovaries are enlarged, right? Because you've got multiple follicles in play. And then there's fluid in the belly from those leaky blood vessels. So things can feel really stretched and uncomfortable. In more extreme cases, it may require monitoring electrolytes, draining off some of that fluid, pain control, that kind of stuff. But again, highly unlikely in this day and age. Any side effects as far as after the egg freezing? Not really. So usually you get a period about a week or two after, and that's your reset button. Then things are back to normal. The ovaries are back to their normal size. Those follicles that were in play that we then harvested eggs from, they were eggs that were going to be, that would have died off on their own anyway. So they're no longer part of the equation, and you're sort of back to where you were with that baseline. I think that should answer kind of where we are as far as potential side effects. Like I said, it doesn't impact menopause because we're not pulling eggs forward. It doesn't have any impact on new onset breast or ovarian cancers. There was concern at one point in time that maybe some of the shots that we used had an impact there, but not having children is a risk factor for those cancers, and we didn't know that in the early days of IVF. So those early studies didn't take that into account. Newer studies that don't show any impact on the medicines on new onset breast or ovarian cancers. So that's a positive thing.
Absolutely. Thanks for the thorough answer, Dr. Mucowski. That also kind of They also addressed the one of the other questions. One of the guests is asking the side effect of egg freezing. It's very it's good to know it's a very mild, it's a kind of a painless and a quick, short and sweet procedure. The next question from Elizabeth, her question is, Dr. Mucowski, how does having PCOS or polycystic ovary syndrome affect a woman's fertility?
That's a huge question. That could be a whole webinar in and of itself. So first off, PCOS is an endocrine disorder. So it's not just fertility related. Women with PCOS have an increased lifetime risk of diabetes, high blood pressure, anxiety, depression, uterine cancer, as well as fertility issues. And that's because part of what's going on in most PCOS cases, so with that, there's a caveat that not all PCOS is the same, is that there's an impact on sort of how the brain and the ovary are communicating that you're not ovulating appropriately or regularly or at all, depending on the severity of PCOS. So obviously ovulation is crucial for conception, right? We need access to that egg so that sperm can encounter it, fertilize, and become, a pregnancy. So depending on the severity of PCOS, someone may need help conceiving with either oral medications to help with ovulation, surgical management, or things like IVF.
Yeah, thanks for that answer, Dr. Mucowski. The next one I have is actually from let's see, this is YouTube. From the YouTube channel, one of the comments says, Dr. Mucowski, I'm a healthy. I consider myself a healthy female, but last year when I did my yearly physical with my OBGYN, it had some bad result. Had a close to 10 follicles, FSH. I think it was follicle stimulating hormone.
Okay.
And my AMH is only a little over 2. So I'm a healthy 20s. I'm less than 20 years. I'm less than 30 years old, but I have a pretty much AMH and the FSH, older than 35. So first of all, is that number? Should I start egg freezing because of that bad lab results?
So it's hard for me to get a clear picture with just those two numbers. I would certainly recommend, if there's any concern, to meet with a reproductive endocrinologist and infertility specialist like myself, because we're focusing just on those things as opposed to a general OBGYN who not only has to know that side of things, but everything pregnancy related, delivery related, all of that as well. So I think it's fair to certainly start with an REI. You may need to have those tests reevaluated. But typically we think of what's called diminished ovarian reserve as sort of what we can see like a less fizzy coke than we'd expect based on age, is defined as an FSH that's elevated. So typically I like to see an FSH that's less than 10, but I want to see that in the first few days of your menstrual cycle, and I want an estrogen level to validate that as well. And as far as AMH goes, we see that AMH is not a great predictor of future fertility in someone who hasn't tried to conceive. So I think it's something, again, that kind of needs to be taken into account with your physician and kind of all the other components at play. And then again, it's going to be very personal and individualized as far as what your family building goals look like.
Okay. Oh, and she just added another comment. And in the meanwhile, Doc, is there any sort of specific supplements that you would recommend if I try to conceive naturally?
The biggest thing is going to be a prenatal vitamin. Right? The idea is it's a prenatal before pregnancy. So it's not something you start with a positive pregnancy test. Ideally, we want you on it for about 3 months before conceiving. And then as far as other things, I think it's more important lifestyle wise to, have good habits, right? We want good diet, good exercise. We want to avoid toxins. Like I said, things like BPAs and plastics, especially in the kitchen. We want to make sure that we're not smoking, that other medical issues are optimized for pregnant state, right? We want to make sure if you are on medications that they're safe in pregnancy. And then as far as other supplements go, it's going to, again, be kind of dependent on who you are, what's going on, everything else kind of in your life. Someone with PCOS, maybe, want to see something like myo-inositol. Someone with diminished ovarian reserve or who's advanced maternal age, maybe things like DHEA and CoQ10 that might help improve egg quality. So it just kind of depends on your individual circumstances.
Okay. All right. Thanks. Yeah, immediately going to type in an answer on YouTube. And the next question is from Facebook. They say, where will my eggs be stored after they're frozen? And how secure are are the techniques?
So most eggs are stored on site at your fertility clinic. There are also storage facilities available throughout the country that you could have them shipped to if your particular clinic is not a long-term storage facility.
All right. And next one is, what will happen if I want to use my eggs 10 years later? I think that's kind of a so I guess maybe she's worried. I think
So
it's a good
say you've frozen your eggs at 25 and you're ready to use them at 35, right? So the idea is then you'd represent to your clinic and kind of reestablish yourself, make sure that you're again, that we've optimized things as far as pregnancy goes, that there are no other factors in play. And then what happens is those eggs are thawed and fertilized with either sperm donor or your partner's sperm. At present, that has to be done with what's called ICSI, or intracytoplasmic sperm injection. And that's because even though the internal part of the egg thaws great, the egg shell ends up being a little bit hard. And so we need to help those sperm fertilize. At current, we then grow them in the dish for 5 to 6 days. And at that point, we have the ability to do genetic testing on them. So things like Down syndrome, learning gender, any other medical issues that are genetic that may need to be tested for. And typically, we then freeze the embryos before thawing them and putting them back in the uterus. And that's because, again, with current technology, we see higher success rates with frozen embryos compared to fresh.
Yeah, awesome. Yeah, that's and another question that they have is, with egg freezing, am I able to request to leave a few eggs in so I can attempt to conceive the traditional?
We are going to leave lots of eggs in, right? We're not pulling eggs forward, right? We're not depleting the pool. We're just saving the ones that would have otherwise died off that month. So you'll still have all the same eggs that were in play beforehand after.
Okay. And how many eggs? This is from another guest. How many eggs should I freeze to be safe? I want to have 2 children. LOL.
That's going to depend on age. So there are statistical models out there where you can type in age and the number of eggs obtained and what the numbers look like as far as statistical perception of the probability of at least 1 live birth, the probability of at least 2 live births, at least 3 live births. No number of eggs is going to guarantee a healthy pregnancy. So, even as we kind of go higher and higher and higher to 100%, it's never going to reach that. So again, that's going to be something that's going to be very individualized based on you and your age and kind of all the other components in play.
Okay. One other question is from it's a YouTube channel again. What this guest is asking is, I live on the West Coast, and the cost of living here is, is quite, as compared to the rest of the country is, is higher. So I wonder if I go, if I just, how much I can save by going to, places like Dallas, long term, like especially for like egg freezing purposes.
It's going to depend, right? I mean, you may end up having insurance coverage that's, would make doing that on the West Coast easier. It may be that you have family somewhere else that makes it easier to kind of travel and spend a week maybe doing the shots and the egg retrieval process there. So I would recommend that you kind of reach out to somebody local, and if you're not really happy with kind of the costs there, then to explore other options.
Absolutely. And should I do more than 1 egg freezing cycles at different age?
Again, very individualized, right? So it's going to depend on how old you are with the first cycle and how many eggs are obtained, and then whether or not your goals change as you get older, right? So again, I usually, after doing the egg freeze process, will put those numbers into those statistical probability predictors so that we can have that conversation. Are you happy with this cohort? Do we think we need more? What does that look like for you?
Okay, absolutely. I think right. We don't have a further question on the other social media channel, and not here either. I think someone should try to type something, but okay. So I think this concludes our Q&A section. So if you if you didn't get to ask your question, or if you have more Like I said, a lot of questions Dr. Mucowski answers very it's individual based. So if you want to have a consultation, want to schedule a consultation with her, I'm going to send out the link again. Feel free to reach out to Dallas IVF and schedule appointment with her. And also we'll send up a follow up. If you're on YouTube or Facebook or WeChat, we'll send out a follow up email to make sure all the links are included, so you can make appointments with either surrogacy site or the IVF sites. So yeah, thank you so much for attending today's webinar. We had a pretty good turnout, especially on the some other channels, like YouTube and WeChat. I think holiday season is approaching, so I'd like to wish everybody a good holiday season. And egg freezing is definitely something to consider, especially you are at a young age and try to advance your career or advance academic achievements. Definitely a good option to achieve more independence, so you can kind of put the worry of a fertility issue behind you. So thanks again for attending. I wish everybody a good holiday, and thanks to Dr. Mucowski for joining us too. It's such a pleasure, such an honor, and also you have the great personal story to tell, to give to feed our audiences, about the egg freezing process, and thanks so much, and that will conclude our webinar.
All right. Well, thanks for having me. Bye.
Thanks.
Bye-bye.
Bye.